Good afternoon. My name is Leslie Moreland, and I have the pleasure of presenting today on advances in the use of telehealth for treating PTSD and working with traumatic stress. And certainly this talk is very timely as we continue globally to navigate virtual care during the pandemic. So just to say a bit about myself, I am the Director of Telemental Health here at the VA San Diego Healthcare System, and I am a Professor of Psychiatry at the University of California in San Diego. So what I'd like to do is talk a little bit about, contextually why we would use telehealth for PTSD treatment, talk a little bit about what we know about clinical efficacy, specifically also things like process and preference variables. Talk a little bit about practice and clinical implementation, specifically how would you get started, how do you adapt some of our established evidence-based treatments for PTSD. Talk a little bit about managing remote risk, which is something that's on a lot of folks' mind when they're doing virtual care. And then highlighting some of the resources that are available for folks as they move forward in this terrain. So to provide a little bit of context, as many of us know, that trauma is unfortunately quite common. Nearly 90% of American adults will experience a potentially traumatic event in their lives. And while not all trauma survivors will end up meeting the criteria for post-traumatic stress disorder, we do know that those that do develop PTSD will be certainly impacted, and all of those that experience trauma certainly temporarily will have some fear, helplessness, or horror. For those who do go on to develop chronic PTSD, they will likely experience a poorer quality of life, impairment in functioning, be at increased risk for suicide, and certainly have more utilization of healthcare, which impacts healthcare costs. So thinking about engagement and completion of effective PTSD treatments, it's really of the utmost importance to both alleviate the suffering of the individual, but also to be thoughtful about reducing the social and economic impact that trauma has on society. So, despite the existence of evidence-based treatments such as cognitive processing therapy and prolonged exposure, to mention a few, and our awareness that these evidence-based treatments can substantially reduce PTSD symptoms, we find with the research that engagement and access in these treatments is still low. And even in places like the Department of Veterans Affairs, where we've widely disseminated and trained folks on CPT and PE, engagement in these treatments is still considered a problem. Access to evidence-based PTSD treatments is even lower in community settings and hospital clinics and private practice settings. And really, with that, there's been a large literature base that has tried to document and in many ways dismantle what are the barriers that individual trauma survivors face when they're trying to access care. And some of these barriers which have been published in the literature include things like geographic distance, travel time and cost, concerns about privacy and stigma, maybe having less specialty providers available to you in your region. And then for a lot of folks, again, just general discomfort with going into a mental health clinic. A lot of these barriers, coupled with some of the characteristics of PTSD, such as avoidance, really make it challenging to receive and engage in effective PTSD treatments. So it makes sense that the novel approaches such as the use of telehealth and technology would be uniquely helpful for this population, given some of these barriers that have been documented. So shifting to talk a little bit about telehealth, in the short space of a few decades, the entire infrastructure for connecting our world has experienced a seismic shift. The pervasiveness of connected technology has enabled changes in how everybody goes about their day-to-day life, how we accomplish daily living tasks, how we go to a bank, how we shop, even how we maintain relationships is influenced by technology. So it's no surprise that the same technical infrastructure has inspired clinicians and patients to seek out technology as a solution to circumvent some of these very intractable barriers that have historically really limited access to delivery of treatments and access to these post-traumatic stress disorder treatments. When I speak about telehealth, which is sometimes referred to as telemental health, when we're looking at mental health care, it really is the use of electronic communication technology to provide support for healthcare when a patient and a provider are not in the same room. So really the most widely studied telehealth modality is video conferencing, sometimes referred to as clinical video telehealth. And this really allows a therapist and a patient who are in two very different locations to interact in real time, often referred to as synchronously. And in many ways is the technology that allows for the most mimicking of the real in-person traditional services where a patient and provider are interacting in real time, ideally in very similar therapeutic kind of virtual settings and conducting for the most part the same treatment that they would do as in traditional in-person care. Although research has supported for over 2 decades the value of telehealth or clinical telehealth, certainly the COVID-19 pandemic has dramatically accelerated the initiatives that were already underway. And in many ways, in the last 2 years with the pandemic, we have had to pivot over to embracing telehealth. But perhaps what's been very valuable is that this has required a push on policies almost overnight to allow for the world really to be able to start to use telehealth and looking at lifting barriers, whether that be technology infrastructure, whether it be barriers with regards to licensure. For example, guidelines around practicing telehealth and reimbursement during the pandemic has rapidly evolved, really to allow this type of care that we have known for a long time to work and to be clinically effective, but barriers such as technology, reimbursement, licensure regulations during the pandemic have temporarily been lifted, and as we navigate the pandemic are now kind of evolving to a place where it's going to allow a more sustainable model of telehealth care. So really the expansion of telehealth has tremendous implications for addressing some of the barriers that trauma survivors have faced. Again, thinking about capacity for patients to have access to specialized providers are no longer limited to just a geographic region, but with telehealth can open access across a state, across a nation, and in some ways even globally. It could allow specialty PTSD therapists to be available in real time in almost any location, crossing time zones. So really there's a lot of implications for access and capacity, and also keeping in mind quality of care, which the research has certainly been able to support. Moving over to looking at many of our PTSD treatments and how telehealth can help, when we think specifically about the value of telehealth for PTSD, many of our evidence-based treatments require that patients see a therapist at least weekly, sometimes twice a week. And the ability to do that and complete these treatments outside of clinic hours with telehealth makes scheduling easier and eliminates some of the barriers that have really impacted patients' ability to attend and complete these evidence-based practices that can be upwards of 15 sessions. So the flexible hours, the reducing of the travel barriers, particularly for things like work responsibilities, childcare. A big one, again, as we mentioned, is stigma, the idea that a patient can seek services and not have to walk into a mental health clinic and run the risk of feeling like their privacy is going to be impacted. Some of the other advantages for PTSD has been the important role of involving family members. And if you can imagine the logistics of trying to get one person into a clinic, it's far more complex when you're trying to get multiple people into a clinic. So really going to the patient where the patient is in their home affords us an opportunity to really involve family members in the therapeutic process and impact their support network. For example, we just finished a large trial here looking at providing virtual couples therapy to veterans with PTSD and their partners. And what we found over this 5-year trial, which also was completed during the pandemic, was that providing CBCT to couples with where one has PTSD was just as effective when we did it virtually as it was when they came into the clinic to receive these services. To say a little bit about clinical efficacy, for folks that may or may not be aware, it's important to highlight that certainly prior to the pandemic, there were several decades of very rigorous research trials consistently showing that mental health services, including both psychotherapy and psychiatry, could be delivered both over clinic-based and over home-based clinical telehealth modalities. And it did not impact the efficacy of what was being provided. So in many of these studies, for example, the ability to improve symptoms such as PTSD, depression, and anxiety, the efficacy was comparable to the studies that were done in person with traditional care when it was provided virtually, really supporting that we know that we can maintain the integrity of our evidence-based treatments for PTSD, even if the patient's not in the room in front of us, but maybe in a different city, state, or country in many cases. A common concern when we've gone to virtual care is whether or not our therapeutic process factors, such as therapeutic alliance, attendance, treatment adherence, are going to be impacted. And what we have found is that, again, consistently over numerous trials, therapists are able to be as adherent to the protocol when they're doing it virtually as is when they were doing it in person. What we have found is that treatment retention is comparable. In some cases, treatment retention can be better when you're doing it virtually. And therapeutic alliance and satisfaction has been comparable. Interestingly, there's two studies that were just recently published. One is with CPT and one is with PE, where they compare different treatment modalities for getting trauma care between telehealth and virtual care and actually going into a person's home physically. And what they found in both of these studies consistently was that providing care virtually was actually much better for treatment retention than the traditional office-based care. In fact, the traditional office-based care in both of these studies that were done in separate states, separate studies, found that coming into the office to get your care, which is our traditional model, had the highest treatment dropout relative to the other two arms. So certainly virtual care for PTSD has been well researched. And despite the research prior to the pandemic, it wasn't being done by the majority. Certainly now during the pandemic, the majority of folks are doing virtual care and could have the comfort in knowing that we know how to do this well, and the research really supports us being able to do this effectively. So what we know is that when we look at preference, this is a little bit of a trickier question, that there really has not been a lot of studies that have looked at preference. We've looked a lot at patients' willingness to do telehealth, and what we know is that patients, including PTSD patients, are very receptive to receiving both medical and psychiatric services for PTSD through technology. There has been a few smaller studies that have looked at variables such as age and gender and how they may play a role in a patient's willingness to do virtual care. For example, we found in the study that women, much more than men, were really wanting to do virtual care in the VA if it was being offered to them. And again, there has been some studies that have shown some people really want to do in person and some really want to do telehealth. And so really this is an important area for future research. The challenge has been that prior to the pandemic, most patients weren't really given an option to do virtual care. It was some clinics were offering it and some weren't, but people weren't systematically offered virtual care. And during the pandemic, we've kind of had to pivot to the other direction, where a lot of patients weren't necessarily given options to do in-person care. They were kind of given only the option to do virtual care. The hope is that with time, as we kind of learn how to work with the pandemic and navigate care, both in person and virtually, that we can move to a place where we can move from willingness to preference and really start to look at what are the factors that influence who prefers what type of modality. And how do we use this information to really consider preference as a factor in terms of how we provide care for PTSD patients? So it's suffice to say that we have a lot of research that really supports that we can do virtual care for trauma survivors well, that in general, patients are receptive and providers are receptive to this. I do want to shift a little bit to what we've learned about how do we do it well and what are some of the logistics of doing virtual care for PTSD and what are some of the clinical considerations. Some of what I'll talk about is very specific to implementing protocols like prolonged exposure therapy, cognitive processing therapy, working with trauma survivors. And some of it's going to be very general and can be really generalized to all of mental health care patients and what we want to be thoughtful about. So when we talk about getting started, most of us have learned quite quickly that it's essential to have a platform that provides secure encrypted video conferencing. During the pandemic, we were able to use any platform. A lot of the barriers were lifted. However, really clinically, it's necessary that when you're doing telehealth that you are working with an encrypted platform. So it's secure and confidential. It's also necessary to establish that both you and the provider, or you and the patient rather, have a strong internet connection. Ideally with adequate bandwidth. I will say that this is something that providers are often able to establish, and sometimes we have to problem solve with patients on how to make sure that their connection is going to be viable. Most platforms have an option to check connection speed, and ideally in the beginning of the therapy process, you can work with a patient to check if they have the broadband internet connection. And if they don't, really troubleshoot with them on how to find a way to get that connection. Do they have hotspot access? In some cases, we may work with them to go to a location where they can toggle off the nearest kind of public Wi-Fi. Sometimes it will be a library. Sometimes it'll be the nearest Starbucks. But really looking at creative ways to make sure that the connection is established for that patient. And sometimes it's going to be in their home and sometimes it'll be in their car, but really being thoughtful about how to make this work, not just on your end, but on the patient end. I think one thing we learned during the pandemic, particularly when people had to quickly set up an office in their home, was that the home office is just as important as the patient end, where we really want to be minimizing distractions and really, as much as possible, mimicking the professional office that you have in your office to be in your home office. So not having distractions like pets, not having distractions like children in the home, which of course has been a challenge for many of us. Ideally creating a waiting room feature with your platform so you can increase privacy and you can decide when it's time to let the patient in to that waiting room. This feature is very important when you're offering group therapy, CPT groups or couples therapy, when you want to really determine when do you want to start the therapy and you let the person into that waiting room. So really being thoughtful about the things that you want to set up in your home office in order to, as much as possible, mimic what it would be like in your traditional office. What I would say on the patient end, all of that applies, but what is very challenging, I think, particularly with PTSD care, is really setting up an environment that, again, mimics the therapy and really educating patients on what constitutes a therapeutic environment. So, for example, ideally a private location, ideally educating folks on their confidentiality and kind of what is necessary to feel safe to be vulnerable in the therapeutic environment. Things like pets, things like turning off other devices so they're not getting interrupted during the therapy. Certainly not doing telehealth while you're driving. Just like someone wouldn't come into your private office and be cooking a meal or eating a meal, you would really have that same behavioral expectation set up for them doing virtual trauma work from their home. And I would say that a lot of this, the more you can set this behavioral expectation on the front end before you start the therapy, the less likely it will interfere with the therapy. And this is something that has required a lot of education and a lot of behavioral expectations. We actually have them sign a behavioral expectation contract in order for us to increase the likelihood that the therapy will go successfully, even though it's in fact virtual. I will talk a little bit later about setting up clinical contingency plans for emergencies and what's required for the patient in their home. I will mention that we don't do any therapy with a patient unless we know exactly where they're physically sitting. We want to know the address of where they're sitting in case we needed to deploy some type of emergency services. And also for licensure issues, depending on where you're working and what you're permitted to do. Typically, you need to be licensed in the location where the patient is sitting, not where the provider is sitting. And I'll talk a little bit about some of those regulations because certainly those are regulations that are rapidly shifting in order to really remove barriers to care and increase access. When we talk about the virtual assessment and file sharing for PTSD treatment, as you know, regardless of what treatment delivery method you may be using, whether it be in-person or virtual, really we do a lot of measurement-based care. We do a lot of assessment of PTSD symptoms. We want to be discussing treatment options when we initiate treatment. And many times this requires exchange of documents, files, measures. And so we really want to be thoughtful in advance about how am I going to be able to exchange information during the therapy session in a way that is going to have the technology be on the backdrop and not interfering with this process. So it's really helpful before you start therapy to be thoughtful about what's necessary to effectively exchange this information. So a lot of what we look at is ways that you can securely exchange assessments and file exchange. So conventional email platforms don't always have the appropriate levels of security for email exchange. So what we really would like folks to do is be looking at ways that they can share encrypted email information and secure transmission. In the absence of being able to do this, what we ask people to do is looking at share screen functions. So depending on the platform, you can share screen when you're introducing a new skill. If you are looking at reviewing practice assignments, if you want to be looking at assessment measures, you can allow them to share their screen, or you can model how to share your screen and show them how to complete an assignment. In the absence of being able to do this with encrypted email, we will do a screenshot and have them save it on your platform. One of the things that's been really helpful with virtual care has been introducing mobile applications, particularly those that complement our PTSD treatments. And these integrating these mobile applications and texting tools for telehealth has really furthered the potential to improve engagement and to reduce barriers. So it really allows for a completely virtual model of care when you can take a telehealth, video telehealth, and complement that with these mobile applications. It allows a therapist and the patient to extend the therapeutic window through the use of messaging software between sessions to be able to have the patients answer questions, transmit homework, or identify items that need to be discussed in the following sessions. So things like PTSD Coach, and I'll talk a little bit later about CPT Coach and PE Coach. These allow treatment features that can help us assess, educate about PTSD, allow us to assess PTSD symptoms, allow us to assign skills. And although these apps have been used as standalone, what we have found is that using them to complement virtual care has been incredibly helpful for the provider and for the patient. As I mentioned, you can assign self-management tools within these apps as well. And one of the apps that we've also used in addition to CPT and PE Coach has been the virtual hope box for suicidal ideation. And this is a virtual way that you can have the patient actually develop a suicide risk plan. And so really being mindful of when you're doing telehealth for PTSD, really harnessing the benefits of a lot of these mobile applications that complement the treatments and allow for a smoother virtual care model. One of the things that we've also really tried to pull in with virtual care is using the shared decision-making tools that are offered through the National Center for PTSD, particularly because we want to be assessing when you start PTSD treatment and you're considering this to be 100% virtual, and in many cases, if it's during the pandemic, really being thoughtful about, can you ensure that your patient is going to be able to establish a virtual environment that allows for privacy, that allows for minimal disruption if they don't have childcare. Really being thoughtful about setting it up for success. While a patient and provider may have a virtual connection, can the patient commit to doing trauma work during circumstances that they might be virtual? Are they able to do this in their home? While we know it can be done, are there circumstances, perhaps during the pandemic, allowing them to engage in this therapy? So really being thoughtful on the front end about doing virtual care and choosing what is the best treatment option for them given the current circumstances. And also being mindful that you might have to disentangle some of the PTSD related avoidance that you might be working with, and how is that separate from some of the avoidance that we might see that is realistic appraisals of risk during a pandemic. And knowing that this does come into play a little bit more now in virtual care while we're also navigating the pandemic, but being thoughtful on the front end, is this a good time to do virtual care above and beyond whether or not the technology allows us to do it? So I'm going to move to talking a little bit about how we do evidence-based treatment for PTSD via telehealth. And I would start by saying, really, in most situations, there's not a lot of meaningful differences in either the structure or the process of how we implement PTSD protocols. For the most part, we're going to be doing treatment as usual over telehealth. With that said, the more you have on the front end, problem solved technology issues, problem solved how to set up a virtual therapeutic environment, you have a contingency plan in place, assuming all of that has already been discussed, really you have set up an environment that you should be able to very successfully implement CPT and PE or written exposure therapy, whatever kind of trauma-focused intervention that you want to choose virtually. You should be able to do it the same way you have been doing it in your office. And this is really important to know because you really do want to set up the expectation both for yourself as a provider, but also for the patient, that we anticipate this to be as effective with regards to symptom improvement as our traditional face-to-face delivery modality. There's no reason to think that this wouldn't be comparably effective. There are some small adaptations that we do over telehealth for CPT and for PE, and we'll talk a little bit about those. But we really want to go in with a mindset that this is really no different than doing it in the office, because I have created a virtual environment that should very much mimic what we have in the office. As I mentioned, as much as possible, we try to integrate in both the CPT and the PE mobile application when possible. One thing I would say is that if your patient is using their mobile app, if they're using their mobile phone for the televideo conferencing connection, they will not be able to access both the app and the connection at the same time. If, however, they're using a tablet or a computer to do the video teleconferencing connection, they will be able to access their mobile app at the same time. Why that's important is that if they're on their mobile app, for the video teleconferencing, you just want to be thoughtful that this is something that they can download, not during the therapy, but maybe before the therapy or after the therapy. And I will say that more and more patients are using their phone to do the video teleconferencing. And so you just want to be mindful as you integrate these apps that might be something you want to be thoughtful about. So what I would say is one of the challenges with these treatments when we do them virtually is that you cannot just hand a patient a measure, you cannot just hand a patient a workbook. So some of the helpful strategies that we have been looking at is how to get the patient these materials in advance. So we talked a little bit about this with sharing documents, but really being thoughtful, do I want to mail a whole binder to my patient in advance? Or can I send this electronically through secure email? Keeping in mind that not everybody has access to printing. So a lot of times we do mail out these bound materials. We will ask the patient what their preference is, because a lot of times people really do like to have a hard copy. So we will mail the whole bound materials in advance, or if they prefer, we can send it electronically. It is important at the onset that the therapist and the patient have both materials for the therapy, and that they're both reviewing and looking at these worksheets together at the same time. Again, this could be done with a bound material and hard copies. It could be done through secure email. And in many cases, it can be done through screen sharing and holding up a screen and really going over the materials verbally. One of the functions that we've used a lot is Whiteboard through the delivery of treatment. This Whiteboard can be done with a traditional white grease board that you have on your office, and you share screen it and make sure it's in the patient's view. I will say more and more platforms have electronic whiteboards that also is a function that you can use. This whiteboard is really helpful to stay on track, even if the care is virtually, to set an agenda, review the agenda, to walk the patient through worksheets and concepts on your shared screen. We do this a lot for CPT. We, together with a shared screen, will create a stuck point log. We'll go through the challenging worksheet log together. For PE, we might together create their hierarchy. You really want to, as much as possible, mimic what you would typically do in a session where they might have a workbook and you might have the workbook. You just want to have this virtually and do this exchange through share screen when possible and integrate a whiteboard. What I would say is that for trauma-focused treatment, which right now a lot of it has been virtual during the pandemic, there are some wonderful resources. I want to highlight these 3 particular articles that came out in the last couple of years at the peak of the pandemic in 2020. They really highlight specific adaptations that some of the experts in the field have been able to kind of review for folks on conducting prolonged exposure therapy during the pandemic and conducting cognitive processing therapy. These articles will not just talk about virtual care, but also specifically about how pandemic and fears around the pandemic have seeped into the trauma work. Whether it be looking at increased anxiety, whether it be trying to set up in vivo exposures. They really help as a resource to give clinicians some information on how to navigate that. What I would say is that the adaptations for imaginal exposure in therapy are largely unchanged. As we know, exposure is a key ingredient for treating PTSD, a key ingredient certainly of prolonged exposure therapy. And when we're doing this over telehealth, we just want to be mindful to be aware of what part of the patient's body is not in the camera view. We want to be thoughtful about what we cannot see visually, that we might have to be asking more questions and assessing what the patient is doing, what body language that we might not be able to see. We want to be kind of asking them to convey that verbally. One thing you want to be thoughtful about is it's really imperative for the imaginal exposure that the patient be in a quiet setting. I know we want to set this up from the onset of therapy virtually, but particularly for these imaginal exposures, being mindful about the patient's comfort level, that they're in a private environment, that if there's other people in the home, that they feel safe enough to do this, that they're not in some way holding back because they feel like their privacy is in some way impacted. So really ensuring the private space. The other thing is to keep in mind that they're not engaging in any type of safety behaviors that are out of the view of the video conferencing view. So for example, a patient may be, have a pet in their lap that they're petting, but you don't actually see them doing this because it's out of the view of the provider. So really being thoughtful about how you can make sure that you're not missing important components that in fact could interfere with the exposure strategies. These are techniques that we have found to be very helpful to make sure that we're maintaining the integrity of the treatment, but still being virtual. I will say that in the articles that I mentioned a few slides back, there are some recommendations of how to do some PE adaptation exposures when someone might be in their home and not maybe out and about because of the pandemic. What are ways that we could have them still do some exposures around some of these themes like anxiety, grief, loss, trust, but still maybe maintain the safety of being in their home. So I won't go through these now, but some of these recommendations are in these articles. Similarly, there's some recommendations for in vivo outside of your home exposures during the pandemic. For example, not going into a busy restaurant that's indoors, but maybe looking at opportunities to go to a restaurant that's outdoors that still maintains some safety during the pandemic. So some of the adaptations, not just necessarily for virtual care, but keeping in mind that a lot of virtual care with PTSD is also overlapping with some real fear around safety with the pandemic, and looking at some ways that we can still do PTSD treatments in these kind of circumstances. I do want to talk a little bit about managing risk and safety remotely. One is that we know certainly with trauma work and PTSD that there is a risk with suicidality being a little bit more increased. And one I would say, as someone who's done a lot of telehealth for many years, this really has been a reason why a lot of providers might have been apprehensive to do remote care, is they're concerned about how well we can manage risk and safety remotely. So I do want to touch a little bit on this and having a good plan in place. What I would say is, regardless of your patient population, you always want to have a contingency plan in place. You hope you don't need to use it, but the more you have it in place, the more comfortable you will feel as a provider, and certainly the more comfortable the patient will feel. Certainly you want contingency plans that are for clinical risk, both medical and psychiatric, but you also want contingency plans around technology issues. So if the technology goes down, what do you do if you're in the middle of an intense session? Maybe it's not a risk situation, but it's a situation that you want to make sure that you have an ability to reconnect with the patient. So you always want to have a plan of what we do if the technology goes down. When do we reschedule? When do we resume by phone versus video? That should be well covered before you start any kind of mental health care that you're doing, but particularly care with trauma. Certainly with emergency risk, you always want to, well before you start therapy, have information about where the patient is sitting. Physically. For many folks, this could be within their community, and so they know where the nearest hospital setting is or who to call the emergency team. But increasingly, what we're finding is that the parameters of where we see patients virtually is getting larger and larger. So it may not be in your community, but it may actually be within your state, but a totally different community that may be hundreds of miles away. It may be not even in your state and maybe within your country. It could, in some circumstances, be globally. The onus is on the provider to know where that patient is sitting and to know what are the emergency plans that need to be deployed in that geographic location if there is a risk. So I need to know where my patient is sitting, who do I call? What is the phone number? And keeping in mind, 911, if you call it from where the provider is sitting, is not going to get you emergency help where the patient is sitting. So there's been a lot of planning around this. In the VA system, we have what's called E911, where you can call E911 and immediately it'll take you to the geographic location of where your patient is sitting. The point being is that before you start care with a patient, not only do you need to know where they are, but you need to be prepared. If I were to deploy some type of emergency service, what is the nearest hospital? What is the phone number for the police that I would contact in case of emergencies? And the other thing is we usually want a patient support person identified, and we get a release of information for that patient support person. So if there was a risk, I have a person that patient has given me permission to contact who is willing to, either they're maybe in the home, maybe they live close to the patient, but they're willing to step in and do a wellness check on the patient. Now, in the case that a patient won't give you that, certainly you can proceed with services, but you want to make sure that you have access to local resources if needed. But my experience is that patients more and more are willing to give you this patient support person. Ideally, you and the patient have agreed upon plan for what would happen in the case of emergencies, and you have this documented in your consent form, and you have it documented in your notes, and you are able to quickly deploy this. I will say that there is, again, being thoughtful about jurisdiction lines and being aware of laws and licensure regulations. As we open things up more and more, we want to be mindful of these contingency plans and be mindful of, as I mentioned, how to quickly deploy them, both in real terms, but also have this documented from the very beginning. We here in the VA have this in place, and I will say that we have used it, and it has been very helpful to have it in place in advance, and has provided a lot of comfort for patients and for providers. What I would say moving forward is that we are continuing to adapt and refine processes to really embed new technology into the fabric of how we provide mental health care. I think it's safe to say that as we navigate the pandemic and learn to live with COVID-19, virtual healthcare will continue to be the fabric of the landscape for mental health care. It may be the silver lining that we've been forced to embrace it. And in many ways for PTSD services, it really allows us to be mindful of how we can expand access to care, how we can expand access to specialty providers, why we maybe don't have to be limited by local availability. We can be thoughtful about setting up virtual PTSD specialty clinic hubs, partnering with communities, with schools, creating a network of both national and global specialty providers, and really help increasing access. And I would say that the procedures and policies that are being established are only going to open up opportunities for us to expand our reach, which has a lot of implications for what we are able to do with regards to disseminating care. In closing, I would say that, as many of us know, trauma is common. PTSD, unfortunately, is a prevalent condition for both civilians and for veterans. And untreated PTSD can take a tremendous toll on individuals, on society. It has a toll economically for those experiencing traumatic stress. Technology has and continues to change the landscape of how we can provide care for trauma survivors, really across the continuum of care, whether it be in an immediate response to a disaster, or if it's for more chronic PTSD and increasing access to specialty providers. I think we're living in an age of unprecedented opportunity. We know how to treat PTSD. We have effective treatments, and with technology, we have an opportunity to really efficiently disseminate and engage patients in these treatments. Really, telehealth can have a benefit of having this kind of ubiquitous presence and can allow us to support synchronous communication for PTSD providers and patients. while maintaining, I think, the effectiveness and the integrity of decades of research showing us how to treat PTSD well. And be mindful about, increasing privacy when we think about our patients needing PTSD. So really being thoughtful about how this offers a path towards really not just improving engagement, looking at efficiency, but also potentially reducing access disparities in communities that might not otherwise have access. So I do want to highlight resources. This is just a few resources that are available. On the left of this slide, if you work within the VA system, there's a tremendous amount of resources that are updated weekly. If you don't work within the VA system, there's also a lot of resources through services like the American Psychiatric Association. They have toolkits. American Psychological Association has toolkits. They have American Telemedicine Association. But really, there's a lot of resources available for folks to know how to do this and to do this well. And then I have certainly provided a lot of references to really back up a lot of what I've said, but I do want to also let folks know that certainly I would be available for questions both through UCSD and through the VA. If people are trying to get something started or want to get in touch with someone who might be helpful, if I can't answer your question, certainly I can put you in touch with someone who can. Thank you very much for your time.